Hi, I'm Dr. Bryant England, rheumatologist at the University of Nebraska. Thanks for joining me today to discuss some key points in the treatment of RA interstitial lung disease. The first key point is that the right treatment for RA interstitial lung disease starts with doing the right assessment of RA interstitial lung disease. Now, when we think about assessing for interstitial lung disease, there's some core things that we need to do. Our best test is a high-resolution computed tomography imaging of the chest. This is a non-contrast image that tells us information about the pattern of interstitial lung disease, the extent of interstitial lung disease, as well as other relevant findings, such as airway disease or nodules. Complementing this, we want to obtain pulmonary function tests, complete pulmonary function tests that include spirometry, lung volumes, and diffusion capacity, with our forced vital capacity, our total lung capacity, and our DLCO being the measures we most closely monitor. We want to remember to talk to the patient and ask them about shortness of breath, dyspnea on exertion, cough, and assessing what their current activity level is. And then finally, we want to follow these values over time, because even more informative than a detailed assessment at one point is understanding what the trajectory of their imaging, their pulmonary physiology, and their symptoms are over time. But assessment of RA interstitial lung disease doesn't end with assessing the ILD. We also need to assess the other systemic aspects of disease. So this includes assessing their joints and measuring disease activity and functional status. We want to assess what therapies patients have been on in the past, whether these have been efficacious or not, and whether they've had any adverse effects from these medicines. Once we've done this, we can really start to understand where on the spectrum of severity a certain patient falls. We can have a spectrum of severity for the lung disease. We can have a spectrum of severity for their articular or other systemic manifestations. And we want to understand that first before we start talking about treatment. Once we've established where on that spectrum a patient falls, then we have a couple options. So we have an option of using immunomodulatory therapy, and we have the option of using antifibrotic therapies. Now, with the immunomodulatory therapies, one of the first questions that comes up is what do we do with the therapies patients might already be on when we detect interstitial lung disease? This is particularly the case with methotrexate or tumor necrosis factor inhibitors, which some people have concern about the safety of their use in people who have ILD. Now, some recent data is suggesting maybe we were a little more concerned with that than we need to be. But each of those decisions is individualized on a patient-by-patient case. A question we have had is how those immunomodulatory therapies might stabilize lung function over time. And some recent data suggests that indeed, if we use immunomodulatory therapy for patients with RA-ILD, we might stabilize both their FVC or DLCO values. Now, recent ACR chest guidelines have highlighted some specific therapies we might prefer to use in people who have RA interstitial lung disease. These include azathioprine, rituximab, and mycophenolate and cyclophosphamide. Now, I don't frequently use mycophenolate or cyclophosphamide in RA interstitial lung disease, in part because mycophenolate really doesn't have any efficacy for articular disease and because of the serious toxicity of cyclophosphamide. In place, people frequently will use abatacept or tocilizumab instead. In addition to immunomodulatory therapy, we have antifibrotic agents we can use to help slow progression as well. These include nintedanib, pirfenidone, and then the newest medicine that's being evaluated right now is nerandomilast. What we do know is that when we are choosing these therapies and working with our patients to treat RA-ILD, that RA-ILD management is a team effort and not a one-time event. So for these patients, we want to engage a pulmonologist to be part of the care team. Pulmonologists are very useful in helping us monitor the disease over time, the symptoms, their pulmonary physiology, interpreting their chest computed tomography images. When we measure those, again, we want to measure those over time to understand the patient's trajectory of disease as we're intervening. And if we see signs of progression, either by symptoms, physiology, or chest imaging, we need to think about making adjustments to their therapy. We need to think about maybe having this patient evaluated for lung transplant, whether this patient might need supplemental oxygen or benefit from pulmonary rehabilitation. So in conclusion, the treatment of RA-ILD starts with thoroughly assessing the systemic nature of RA interstitial lung disease, evaluating the lungs, evaluating the joints, and other systemic manifestations. We have immunomodulatory and antifibrotic therapies that we can use to try and slow progression of this potentially devastating disease. Unfortunately, the evidence for a specific agent to prefer over another is rather weak, so all of these will be individualized decisions. And we need to engage and build that multidisciplinary team to optimally care for these patients over time and monitor them closely over time for any signs of progression of their disease. So thanks for joining me to watch and talk about treatment of RA interstitial lung disease.